Now let me show you some ECGs. These are very much important. ECG are being asked. Sometimes they are being asked, so we cannot just leave a chance. Let's see, you must be knowing P wave is for sinus, this from sinoatrial node. P wave is for atrial contraction. Then it comes to AV node. Then it goes to spreads to the remaining ventricle. So the P wave suggests what? P wave shows the atrial contraction. Then if someone asks what is PR segment, PR segment is showing what? It is showing the silence, cardiac, electric silence. Means what? During that period, that impulse is inside the AV node. Okay, then it will be going to the bundle of His and Purkinje fibers and all, and inside the ventricle it will go. So that will be given by QRS. So ventricular depolarization is mentioned by QRS. And finally, T wave is for repolarization. So that is ventricular repolarization. Ventricular repolarization is shown by T wave. Someone may ask, sir, what about atrial repolarization? So my dear, when ventricle is getting depolarized, at the same time, atria is getting repolarized, which is having more muscle tissue, ventricle. So that atrium repolarization will not produce any waves because it will be overshadowed by the ventricular depolarization. Hope this is simple. ECG, you know how many boxes are there. You just remember like this, small box and big box. Hope you can see this image. The one here, these are the big box. See, I am drawing one big box. This is the big box. Okay, one big box is around 0.2 millisecond. 0.2 millisecond. Okay, one small is around, you guys must be knowing, one small is around, let me just write it properly. One small box is around 0.04 second. Okay, 0.04 second. Okay, and one big box is around 0.2 seconds, because it has got 5 small box. One big box has got 5 small box, so 0.2 seconds. So you remember like this, the one big box that I have drawn is around 0.2 seconds. Okay, right. In 1 minute, usually how many contractions are happening? 72. Okay, 72. All right. Now see sinus tachycardia. How do you know? How do you know that this is tachycardia? I will show you some simple trick. You do just one thing. This is the R. This is the R. So in between is the RR interval. Okay, RR interval. So whenever you want to get the heart rate, that is the heart rate is equal to, how do you do it? You just make it like this. You just make it 1500 divided by what? Number of small boxes. See, this you can only do when the pulse rate is regular. Number of small boxes. So how many are there? One big box contains small 5 box, isn't it? So see over here, let me just show you which are the big box. This is big box number 1. Okay, this is the big box number 2, and this is the big box number 3. So almost 3. So these are around 14 to 15 small box. One is having 5. Okay, so divided by around 14 or 15. If I get it, it will be more than 100. So this is sinus tachycardia. Okay, sinus tachycardia. Okay, again over here, see RR. RR is that is the RR interval. This interval, what is the interval? Just count one small box, second small box, third, I mean big, sorry, one big, 2 big, 3 big, 4 big, 5 big, and 6 big. 6 big means how many? 6 big box mean how many? 30 small. Okay, so let me just be very clear. 1500 divided by again 30. So that will be around 50. Okay, is equal to 50. So this is bradycardia. Simple. All right. Then sinoatrial block. See, there is a prolonged block in between. This is sinoatrial block. Okay, this pacemaker, it is not required for you. Yeah, PAC you can remember. PAC, see what happens. PAC also I think we'll just leave. Yeah, this is important. PSVT, that is the progressive supraventricular tachycardia. See here, heart rate will be more than 160, around 160. There can be plenty of causes. Maybe rheumatic heart disease is there, maybe intrinsic abnormality, digoxin toxicity, caffeine, marijuana. These all can lead to PSVT. How do you catch this in your ECG in your exam? See, this is PQRST, PQRST, PQRST. Now what? P, okay, something like this, P, then QRS, then T, then again P, QRST. This was normal, absolutely normal. Now what is happening over here? See, QRST, QRST, P is gone, isn't it? Isn't it? P wave is almost aberrant. Okay, so you cannot just catch a particular P wave, but yeah, it will be regular. People always confuse PSVT with AF. There is no need of confusion. Atrial fibrillation, the definition itself says that it is irregular rhythm. Simple. Irregular rhythm. There is no regularity in that, isn't it? So your atrial fibrillation will be irregular, whereas PSVT will be completely regular. Yeah, you may get doubt between sinus tachycardia and paroxysmal supranuclear tachycardia that I have showed you. Sinus tachycardia will have completely P, QRS, T, whereas PSVT just QRS and T. That P wave is actually, it is preceding the each QRS complex, that is actually aberrant. Okay, so you cannot make out of it. All right. Then the atrial fibrillation. Atrial fibrillation is what? Irregular. See, RR interval small, then again large, then large, then again large, very large, then small, then very large. So it is irregular. So atrial fibrillation is very easy to pick. Okay. Atrial flutter. What do you see this? This is sawtooth pattern of P wave. Okay. Sawtooth pattern. You know what is saw? Sawtooth will be like this. This is the kind of like this. So this is the sawtooth pattern. Okay, it will be like something like this. So sawtooth pattern, it is atrial flutter. Just remember like this. You just have to catch it. Junctional rhythm, not, I don't think so it will be asked, but let me be very clear. There will be absence of P wave, no P wave, and regular rhythm and slow. Junctional rhythm will be always 40 to 60, 40 less than 60, always 40. Okay, then first degree heart block. First degree is very easy, just prolongation of PR. See, normal PR interval is around 0.12 second. More than 0.20 second will be called as prolonged PR, more than 0.20. So here, if you can see clearly, this interval is more than 0.20. How you can count? I told you one big box. Look over here. This is one big box. It will be around 0.2 second, isn't it? 0.20 second, right? So see, this starting from P, how to calculate PR interval starting from this P till the Q, this, that is the PR till the end of this thing. So that will be around PR interval, that will be around more than one big box. So it will be first degree heart block. Second degree has got two types, Mobitz type 1 and Mobitz type 2. See, in Mobitz type 1, what is getting happening? You see P is over there, QRS, T normal, then again P, but little bit prolonged PR interval. Okay, then QRS, T, then again P, and furthermore prolonged. See, here it was just this much, now it has prolonged around this much. Okay, so furthermore prolonged, then QRST, then P very much prolonged, but no QRS. See, PR interval is gradually getting larger, and after that certain point there is a drop in QRS. So that is called as Mobitz type 1. Okay, then second degree Mobitz type 2. There won't be progressively increase, there is persistent increase. Okay, persistently larger PR interval. I think it is not given over here. Okay, persistently larger PR interval. So with that, in between there will be droppage. So it can be 2 gem 1, sometime 2 gem 1, sometime 3 gem 1. Okay, like this. So that is second degree AV block type 2, Mobitz type 2. Right. Then finally, third degree AV block, classically characterized by complete AV dissociation, means atria and ventricle are contracting with their own wish. So how can you make it in ECG? What is important for me? See, look over here, P wave will be persistent. See, this is the P wave, here P wave, very much regular P wave you will find. P wave, P wave, P wave, here P wave, again P wave, again this one is P wave. So it is coming at regular interval, isn't it? It is coming at a regular interval. So P is contracting with its own and QRS is contracting with its own. Okay, so this is complete AV dissociation. Okay, fine. VT, this is classically, monomorphic VT, ventricular tachycardia. You will just get a sign like this, that is ventricular tachycardia. Very easy to identify. Asystole, definitely, no contraction is there, so there is asystole. Nothing can be done. You just have to start CPR. Okay. Yeah. In anesthesia, they'll ask you shockable rhythm and non-shockable rhythm. Asystole, is it shockable or non-shockable? It is not shockable. What do you do by shocking? Giving shock, nothing will happen. Okay. So never give, this thing shock in asystole. You cannot survive, take back the patient. Right. So this was about extra edge for ECG. I have just showed you some of that. Very much, crisp ECG that are very much important for you guys. And that is more than enough for you. Now let's move forward. We will go to, okay, these are all theory parts. You know what is systolic BP, what is diastolic BP. You know this formula. Have you heard of this? That cardiac, let me just write over here. Cardiac output is equal to is equal to cardiac output is equal to SBP, and TPR, that is the total peripheral resistance, is equal to diastolic BP. You remember this, huh? That your systolic BP is decided by your cardiac output. Systolic BP is decided by cardiac output, whereas your diastolic BP is decided by the total peripheral resistance.